FDA-style English, verb choice for benefit-risk claims. Welcome. In regulated settings, words carry weight. Using a regulatory voice helps teams communicate findings clearly and responsibly. First, clear language builds trust with regulators. They need to see exactly what you did, what you found, and what it means. Second, consistent verbs signal evidence strength. When your wording matches your data, reviewers can quickly gauge certainty. Finally, the tone must be neutral, factual, and cautious. That means no hype, no overselling, and no promises the evidence can't support. Think precise, testable statements that let the data speak without spin. To match FDA-style tone, follow 3 rules. 1. Avoid marketing claims and hype. Skip words like revolutionary or guaranteed. 2. State methods and limits upfront. Briefly note study design, sample size, and key constraints before discussing results. This frames expectations and prevents overreach. 3. Differentiate results, interpretation, and advice. Results are the numbers. Interpretation explains what those numbers likely mean. Advice outlines cautious next steps for use. Keeping these lanes separate helps reviewers trace logic and verify that conclusions stay within the evidence. Choose verbs that match your data. For low certainty, use may, suggests, or indicates. Useful for preliminary signals or small samples. For moderate certainty, use is associated with or estimates. Appropriate for observational findings or modeled effects with caveats. For high certainty, use demonstrates, shows, or meets criteria. Reserved for robust, well-powered studies or predefined performance thresholds. Build consistency. Once you pick a certainty level, apply it across the document. Reviewers read verbs as evidence signals, so your latter should map directly to study strength. Keep benefits specific and grounded. Describe outcome, population, and context. Who was studied, in what setting, and what changed? Use data-backed, cautious verbs aligned to certainty, such as suggests or demonstrates only when justified. Provide a concrete frame, baseline versus post-intervention, and relevant constraints. For example, in adult ED patients, the model suggests improved triage time compared with standard workflow. Stronger evidence might read, in a multi-center study, N equals 2, 100, the model shows reduced median triage time. Always connect benefit language to the actual design and metrics. Regulatory readers expect clarity about downsides. Name error types and frequencies, false positives, false negatives, or misclassification rates. Mention data gaps and biases, underrepresented subgroups, drift risks, or limited external validation. Pair this with context so users can act. For example, the model may misclassify rare cases in subgroup Y, especially when feature Z is missing. Add magnitude when available, rates, confidence intervals, or thresholds. Explicit risks help define safe use and support mitigation steps like human review, secondary checks, or restricted deployment scopes. Anchor every claim to study design. Tie claims to study design and N. Retrospective cohort N equals 850, prospective pilot N equals 120, or randomized trial. Reference metrics with CIS/thresholds, sensitivity, specificity, AUC, with confidence intervals or pre-specified criteria. Separate internal versus external validation. Note performance on training-like data versus independent sites or time periods. This structure shows how generalizable the findings are and where uncertainty remains. When evidence differs across settings, state it directly and adjust the verbs to match each evidence tier. Translate evidence into safe practice. Define scope of use and user role. Who should use it, for what decisions, and in which settings. Require human oversight and fallbacks, confirmatory review, second reader policies, or default pathways when inputs are missing. Outline monitoring, updates and retraining triggers, performance thresholds that prompt investigation, data drift alerts, periodic audits and versioning. Clear guardrails turn results into responsible action, helping teams deploy tools that are helpful under defined conditions, and paused when signals suggest risk or degradation. Use these starter lines and fill in your specifics. Benefit. In population and setting, the model indicates direction of effect on metric based on design N. Risk. The model may error type at approximately rate CI, particularly when data gap/bias condition. Use guidance. Intended to assist, not replace, clinician judgment. Requires human review when trigger, with fallback to procedure. Keep verbs aligned with evidence, and update the templates as new validation data refine certainty levels and safe use boundaries.